And I'm very pleased to introduce Dr. Ryan Spencer, who is a cardiologist and physician here in Geelong, who is very accomplished and has working in multiple sites in our region, and we're very pleased to have him help us with our management skills for heart failure. Thanks, Ryan.
Thanks very much. So we'll start with a case. Typical man who you'd see in general practice or in my specialist rooms as well. 65-year-old man, presents with kind of progressive shortness of breath over 6 months, is a smoker in the past, drinks a little bit of alcohol, and you do a bit of examination. He's got maybe some crepitation, some peripheral edema. A chest x-ray shows heart failure. I'm not going to ask you what you do, I'm just going to ask you, how worried are you about this patient? If the next patient came in and they said, I saw someone last week and I had a biopsy and I've got pancreatic cancer, which patient would you rather be? Pancreatic cancer, anybody? No, okay. Heart failure? Okay, it's close. So the chance of dying in 5 years for this guy is 50%. And in fact, the number of deaths that occur due to heart failure compared to pancreatic cancer or prostate or breast, I mean, this is raw numbers, not, percentages. But the number of deaths caused by heart failure is more than those cancers. So even though we have a lot of good therapies these days, mortality and morbidity as well is still very high. So I think it is worthwhile revisiting. So I'm going to just talk about some principles of management, about getting euvolemia, and then some prognostic therapies. We'll go through some of the options, and hopefully we'll touch on some of the pitfalls and the tips and tricks of using these agents in clinical practice. So I think it's important to start with this one. And really, heart failure is congestion and exercise intolerance. And so, congestion manifests in many ways. Edema, elevated JVP, shortness of breath because of high filling pressures, crackles in the lungs, and then exercise intolerance. Some people won't say they're shortness of breath. That very common symptom of fatigue may just be the only thing they're kind of experiencing. At this point, with our man, Mr. BNP, what would people do next in terms of investigations? Any suggestions? Yeah, I agree. And considering I spend most of my life reporting them, the main question here is, what is the systolic function? Because if the systolic function is reduced, that puts them into a specific category. If it's normal, then either we've got to rethink our diagnosis about what's causing the shortness of breath, or maybe they've got that difficult to manage and vague symptom or diagnosis of heart failure with preserved ejection fraction. So yeah, the most important thing is, where do they sit on this classification? And we really don't bother using the middle one anymore. It's kind of introduced for research. Really what you're asking is, do they have a reduced ejection fraction, which these days we would say basically is less than 50, or do they have preserved ejection fraction? And then if you're convinced that they do have heart failure, then I guess they have heart failure with preserved ejection fraction, which is probably diastolic dysfunction. Another important classification is, where are they along the New York Heart Association's classification of dyspnea? This is important because it dictates the therapies that have been proven to work, in that group of patients. So there's certainly quite a lot of patients that sit in this group. They actually don't have any symptoms, but they have an echo for whatever reason, and they have LV dysfunction. They have a low ejection fraction, and they require therapy despite the fact that they don't have symptoms, or anyway. And then as you go along, the chances of these patients dying goes up, and the therapies that are available to us increase as well. And the easy way to think about it is basically either they don't have symptoms, they have symptoms, they can do their ADLs without getting symptoms, but they have to push themselves further to get shortness of breath, or they get their symptoms, their shortness of breath during ADLs, that would be class 3, or they've got breathlessness all the time, that would be class 4. So this is his echo, and trust me, this is not working very well. So this is heart failure with reduced ejection fraction. This is the left ventricle here, this is the right ventricle on this side, these are the atria. So the probe is held from the bottom of the chest looking up, and this left ventricle is not pumping very well, and it's pretty uncoordinated as well. If you just look at that, it doesn't really look like it's coordinated. It's not pumping well. That's because the patient's also got a left bundle, which you can see down in the ECG, which we'll talk about a bit later. But obviously nobody sends you these, thank God. This is what you're going to get. And really the important stuff here is what's going on with the left ventricle. It's mildly dilated and there's severe systolic dysfunction. The rest of it's kind of irrelevant, just telling you there's no significant valvular disease. I guess severe valvular disease could cause LV dysfunction, and this man's right ventricle is involved as well. So that sometimes gives you a clue to causes of heart failure, which we're not going to go into, but coronary disease usually affects left ventricular function only. It often doesn't affect RV function. So this points to more an idiopathic or hypertensive or alcoholic cardiomyopathy, something like that. So yeah, this is really the important information at the top. So he's got heart failure with an EF of 20%, so he's got heart failure with reduced ejection fraction. And in that category of patients, we've got a lot of data. So we started in 1987 with ACE inhibitors, proving massive benefits in living longer, and many more trials with growing numbers of patients as the trials went on, up to 5,000 in some of the trials. So everybody that has heart failure and everybody that has LV dysfunction should be on an ACE inhibitor. Really, the two that were mainly studied were enalapril and ramipril, but we use a lot of perindopril, as you've probably seen. It was never actually studied in heart failure, but we assume it's a class effect. There's widespread underdosing. The trials always try and up-titrate patients to the maximum tolerated dose. That would be, 10 of perindopril, and that doesn't often happen for various reasons, usually low blood pressure. And they're also recommended in class 1 patients, so if you don't, despite the fact that you don't have symptoms. Don't think that's new to anybody. Beta blockers obviously were controversial when they were introduced. How would you go and give a beta blocker to someone who's in heart failure? It sounds crazy, but it turns out it works really well. But there's really only 4 of them that you can use. You can't use propanolol or you can't use atenolol. It almost certainly doesn't work, and certainly things like propanolol are not going to work. Maybe metoprolol, although they did study short-acting metoprolol and it didn't work, only the long-acting stuff worked. The main agents that we really use these days would be probably carvedilol, bisoprolol, and nebivolol. And they both affect immediate sudden cardiac death, so they prevent arrhythmic death, which is important, and they prevent pump failure. And they have a complementary or additive effect over ACE inhibitors. What are some of the common problems that you guys see when starting beta blockers in patients in heart failure? Hypotension, I see that a lot too. So one of the things you can do is think about which beta blockers to use. So carvedilol will definitely drop someone's blood pressure because it's an alpha blocker as well. So it's a potent antihypertensive agent. So if you've got someone with a lot of blood pressure, carvedilol is good. Bisoprolol is really pretty terrible at dropping people's blood pressure. And so that is one that we often use in clinical practice when we're struggling. And you can start as low as 1.25 of bisoprolol and just up titrate slowly. And the hypotension often goes away after a couple of weeks on one dose. It's really not about the numbers either. Most of my heart failure patients sit with systolics of 90 on a good day. It's about symptoms. So if they tell me they can get up from a chair most of the time without feeling dizzy, I'm happy. I don't care what the numbers are. It's really about trying to prevent them from fainting. Conversely, nebivolol as well, very good antihypertensive. In fact, it was designed as an antihypertensive in Europe and has been used that way for many years because it has nitric oxide properties and causes vasodilation. So, but to be avoided in people that you don't have much blood pressure with. And I think the other thing that we see, which is really, I think, more theoretical often than actual, is the asthma effect, or the airways problem. So nebivolol is something like 600 times more beta-1 selective, and really just has no effect on the lungs. And so if you're worried about people with asthma or even COPD, nebivolol or bisoprolol is also very beta-1 selective, would be the top agents of choice. And the other way is just we always start really low and increase very slowly. Start 1.25 of bisoprolol or nebivolol and go up every month, something like that. And you might go up to BD. Don't go 2.5 in one hit, go 1.25 BD, something like that. Split the doses, go slowly. But the aim is to get up onto the top doses. The next level would be spironolactone and eplerenone, the two mineralocorticoid receptor blockers. And there were some trials showing mortality benefit in patients that have significant symptoms. If you've got patients who have ongoing symptoms, that's when we would add spironolactone. Although, obviously, it comes with its own dangers of hyperkalemia, which needs to be monitored, because they're usually on strong doses of ACE inhibitors as well, these patients. And then we have the old ACE inhibitor cough, which often comes up, and half the time you don't know whether it is ACE inhibitor cough or not, but you've really got to try stopping the ACE inhibitor. So you can use ARBs, but really only valsartan and candesartan have been extensively studied in heart failure, so they should be the ones that we're using. And really it should be ACE inhibitors first. If they don't tolerate ACE, then we swap them across to ARBs. Yep. Yeah, I mean, I think there's some theoretical dangers in that group, but the prognostic benefits of beta blockade in people with reduced ejection fraction outweigh the small risks by hundreds of times. So, in terms of stopping sudden cardiac death, they are the best agents that we have. And so potentials with hypoglycemia or worsening of glycemic control are really minimal concerns compared to having VF. Yeah. So there's a few other weird and wonderful agents out there like ivabradine, which slows your heart rate down. It's an incredibly good agent to slow someone's heart rate down if you ever need to do that for any reason, because that's all it does. It doesn't cause low blood pressure, but it's really only indicated in a small group of patients. They have to be in sinus rhythm, and more of our severe heart failure patients are in AF these days, and they have to have ongoing high heart rates despite maximum tolerated beta blockade. And that was because many trials showed that no matter what your drugs you were on, if your heart rate was high, you just tended to do worse. So this agent was trialled, and it did have benefit in both death and symptoms. It's also a great agent for things like angina, because it slows down people's heart rates and prevents angina, and is approved for angina, but not on the PBS for that indication. But there's a new kid on the block. I'm hoping some people here would remember this band. You might have even heard of it. It's called Entresto. So when trying to look at further and further therapies for heart failure, we've gone back and looked at the systems that are involved. We know the sympathetic nervous system's involved. That's why beta blockers work so well. We know the renin-angiotensin system is involved. The renin-angiotensin system is a system that kicks in when you're bitten by a tiger, which was important, but not so much these days. And it holds on to volume at all costs. And in heart failure, you don't really need to hold on to volume because it's not an acute insult, but your body doesn't know that and will try and hold on to volume, causing congestion. But there's another system involved, which we've known about for some time, which is the BNP system. And that's where BNP comes from. BNP is released from the heart when it's stretched. So the thing about BNP is it's good. It's actually a good hormone, and we want more of it. So in many trials, eventually an agent was found that basically inhibits neprilysin, and what neprilysin does is it breaks down good BNP. So if you can inhibit neprilysin, you end up with more BNP and you do better. Well, that was the theory. It was trialled in conjunction with lots of agents, and there was lots of problems, and then they finally came upon the combination of valsartan and the neprilysin inhibitor, which worked well and blocks both systems. And of course, beta blockades would block this system, giving you kind of much more of a total blockade of the bad things that occur in heart failure. And sure enough, if you use this agent, people die less often and they do better. So nowadays, the ARNIs, of which there's only one, Entresto or valsartan sacubitril, is really standard of care for people with severe heart failure. You wouldn't go starting this agent de novo in someone on heart failure. In fact, it's not approved on the PBS for that. So you really need to start an ACE inhibitor first and prove that they don't succeed on their ACE inhibitor. But if you've got someone with ongoing symptoms, you should swap them from their ACE inhibitor or their ARB across to this. Had pretty phenomenal results in its trial. When you think about the amount of therapies that these patients were already on, they were already on beta blockers, they were on ramipril in the control arm, and they were all had devices if they needed them. So that it was modern medical therapy, and we still reduced death and hospitalisation by 20%. So the problem with this agent is that it's a potent antihypertensive as well. So on top of your beta blockade and maybe some spironolactone, you're giving them this. These people really do end up with blood pressures of nothing. So again, we start very slowly, very low doses, and just gradually try and increase. If patients have tolerated the top doses of their ACE inhibitors, that's usually a good sign that they'll do well swapping across to Entresto. But they have to be watched quite closely in the early days because of the hypotension, and we often back off on some other agents when we're introducing it. So the basic tip is to cut their diuretics in half when you introduce this agent to try and give them just a little bit more blood pressure.
So do they stay on the beta block?
Yep. So it's just a one-for-one swap for the ACE inhibitor or the ARB for the new Entresto. Yeah. I mean, that would be, if you had someone who was on their ACE inhibitor and beta blockade and spironolactone and they're still struggling, and you think this could be a good candidate for Entresto, that's a very good reason for a referral. That would be like the best referral I've had in a couple of years. And so there are some problems, the main one being hypotension, but if they can get across onto it, they do very well. And anecdotal evidence out of places like the Alfred that have introduced this in the last few years, they've seen their transplant numbers drop significantly. So it has been, for that level of patients who are in the really severe camp and struggling, it has been pretty phenomenal. So, but the problem is, even with all of this, we still end up with somewhere between a 5 and 10% mortality over 1 or 2 years if the patients are significantly symptomatic, even with all these therapies. And so this is where we looked at devices, because you can see the majority of these deaths, they're sudden cardiac deaths, they're arrhythmic deaths. They're the patients that are walking in and out of the clinic and they look fine, and then they maybe have some symptoms and you're working on them, but you're not really worried about them, and then they just have VF and that's it, unless they happen to be somewhere like this or a golf course. And that's where the devices come in. So you will have all known about standard defibrillators. So just like a pacemaker, at least one lead into the heart which senses, and when the patient goes into VF or VT, waits a short amount of time and then delivers a shock. So indicated for patients with low EF, because we know these patients are high risk at having arrhythmic death, or if they happen to have survived one in the past and we haven't changed what caused that. If they have an ST elevation myocardial infarction, they have a STEMI and they have VF, well, we fix the STEMI, so we assume the VF won't happen again. They don't get defibrillators. But if it's a primary cardiomyopathy or maybe an inherited arrhythmic syndrome, they will get defibrillators. There's a new kid on the block here as well. It's a completely subcutaneous defibrillator. So instead of having to put the wires through the veins, and anytime you have anything that's intravascular, the infection risks are high, and there's something like a 1% chance over a lifetime of getting your device infected, which doesn't sound like much, but then if you get it infected, you have to go to the Royal Melbourne and have it extracted under GA, and that's like a 5% chance of dying from the extraction. So you really don't want to get your device infected. So if you're young, something like this is a better idea. This just sits under the skin on the left-hand side. The wire, the main wire that senses just goes up the middle. This one goes on the outside of the sternum. There's ones that go just under the sternum as well. It's all subcutaneous, nothing in the intravascular space, so it can't get infected. We put these in at Geelong, so they will be around. You will see them. And you can see them. They stick out a fair bit on this side. The other problem that these patients have is ongoing pump failure. So not so much arrhythmic death, but just drifting worse and worse and worse into cardiac failure. And that often ends up with left bundle. This patient's in left bundle, and you can see that discoordination of the heart beating. It's not beating together. The timing of the heart is out. And that's where cardiac resynchronization therapy comes in patients with left bundle. Because what's happening in left bundle is, the septum comes in, and then a few seconds later, a few hundred milliseconds later, the lateral wall comes in. So it's doing this. It's not really pumping. If we can retime the heart so that the septum and the lateral wall beat together, you can get, improvements in EF and symptoms immediately. So typical left bundle, wide QRS showing you the dysynchrony of the heart. We can put 3 leads in, usually one in the A, one in the RV, and one wrapped around the heart in the coronary sinus around to the left-hand side of the lateral ventricle, which then reminds the lateral side of the left ventricle to contract at the same time. You can retime the ventricle, and these patients they'll notice a change when you turn it on the table. Sometimes it is phenomenal. The problem is it doesn't always work, and we don't really know why it works in some people and not others. We wouldn't put it in anyone if you didn't you have to have a left bundle to start with, but even left bundles, some people do really well and some don't. Again, there's a new kid on the block here, and you will see this. So instead of putting a lead across onto the left-hand side of the LV, some smart people thought there's this thing called the bundle of His, which is before the bundle branches. If we can put a pacemaker lead in the His bundle, then the heart should contract physiologically. It should be perfect. You should not even notice on the ECG that the patient's had a pacemaker. And so that's what we've started doing. We can find the His bundle. It's just above the tricuspid valve in the RA. It's not very easy to find, but you can find it. If you can put your pacemaker lead in there, the heart will contract perfectly normally, and the ECG will look like a normal ECG, even though the patient's pacing. And this, in early work, some of which we're involved in, is looking probably even better than CRT for patients with left bundle in terms of re-coordinating their heart. But we would also do this for someone, just a routine pacemaker implant, because the patient ends up with physiological pacing or physiological heartbeats instead of an RV paced complex, which is broad and dysynchronous. Makes it even harder for people to work out that the patient's got a pacemaker. All right. So the typical indications for the CRT would be ongoing symptoms. You have to have sinus rhythm really, although we do it in patients with AF. A really long QRS duration, suggesting there's dyssynchrony in the heart contracting, left bundle, and a low EF. And again, with response, as I was saying, the wider your QRS, the more ugly the ECG looks, the more likely you are to respond. And we've trialled putting this in patients with narrower QRSs, maybe 120, 130 milliseconds, and it doesn't tend to work as good. So they really have to have dysynchrony to start with for this therapy to work. Can you put a defibrillator and a cardiac resynchronization pacemaker together? Well, you can. You can get them both in the one device, and you can have a defib and a CRT device together. And we would use that in, say, ischemic cardiomyopathies who have a high risk of sudden cardiac death and aren't doing well from pump failure point of view. They can get a CRT-D, so cardiac resynchronization therapy, and a defibrillator, but we can also just put in the resynchronization part of it. We did one of these on Friday. It's an 85-year-old man. He's got lung cancer, but it's a single nodule that is hot on PET but no Mets. So we think, he's not going to live forever, but he's got ongoing problems with pump failure, so we put in the CRT type device. We spoke to him for a long time and he just said, I don't really want a defibrillator, and we agreed. So in terms of summary, ACE inhibitors for everybody, beta blockers for everybody, irrespective of their symptom class. The mineralocorticoid receptor blockers, so spironolactone really, is really just for ongoing symptoms. You can use ARBs instead of ACE inhibitors, but nowadays we've got the new agent, the ARNI and Entresto, which is probably going to replace ACE inhibitors or ARBs completely. You can add in ivabradine for ongoing high heart rates in sinus rhythm, and eplerenone is a secondary agent instead of a spironolactone that we didn't talk about much today. It's hard to get hold of. Then what about heart failure with preserved ejection fraction? Well, there's not much around. Probably the biggest trial in heart failure with preserved ejection fraction to date was the TopCat trial, which was negative. It looked at spironolactone, showed that it didn't seem to make much difference. The problem with heart failure with preserved ejection fraction, though, it's like chronic fatigue syndrome. It's probably not one thing, it's probably 10 different things, and if you throw them all in the same bag and try and use a therapy, it doesn't work. But if you could find the right people in that group, these agents probably would work. And so it's really, the difficulty we had with heart failure with preserved ejection fraction is the classification, trying to work out who are those people. So if you do see this in clinical practice, the standard typical patient is usually an elderly female with peripheral edema and shortness of breath, but a normal EF on their echo. And presumably they have significant diastolic dysfunction, so the heart's having trouble relaxing, it's a stiff heart. And spironolactone probably does work, despite the TopCat trial, so we would use that. But the mainstay of therapy is usually, as it would be in heart failure with reduced ejection fraction, is maintaining adequate volume state, maintaining euvolema with loop diuretics, being furosemide. Thiazide diuretics and spironolactone really don't have much of a role to play at affecting volume state. They're not very good diuretics. Some evidence for nitrates might help symptoms and digoxin, but really it's a tough area. The good thing about heart failure with preserved ejection fraction, so if your EF's fine, is that despite what everyone says, sometimes you don't tend to die. So the TopCat trial, the mortality over 3 years in that trial was around 10%, and these patients were, 70s or 80s. It's probably not that different from the background population. The death rate in the Entresto trial, so the latest therapy in heart failure with reduced ejection fraction, was around 20%, 20% in 2 years. So I always tell my patients, it's annoying. I know I'm not saying it's not annoying, and it's very frustrating, but it's not going to kill you. The last point is about heart failure with reduced ejection fraction and their progression. So this is what we see in the typical hospitalised patient. They're doing okay, they come into hospital with a decompensation, they never quite get back up again. And it just keeps going down and down and down. Every time they get hospitalised, they get a little bit better, but they don't quite get back to where they were. And 3 or 4 years later, they're dead. So it's important for us to think about what causes those decompensations and try and identify those patients that are on that downward trajectory and use those increased therapeutic options available, like Entresto and like our devices. And the typical precipitants are ischemia, which can be silent in these patients. Arrhythmias, especially someone going into atrial fibrillation, could be enough to cause a decompensation. Not adhering or not understanding necessarily the importance of fluid restriction and sodium restriction. Medication adherence is obviously critical, or superimposed infection or iron deficiency. This would be the standard list that when someone comes in with heart failure to the hospital, first thing we think about is this. What on this list has happened to prompt them to come into hospital? Okay. Questions? Go for it.
with your patient, Mr. BNP, who walks in, bit breathless, bit edematous, do I send him to hospital, do I not send him to hospital, I'm going to do an echo, what am I going to do? What's your first move? Do you send him out with nothing? Do you send him out with some frusemide? Do you send him out with an ACE inhibitor only? What do you do with him on day one?
Yeah, so I think everyone heard the question, but it was that first patient, Mr. BNP, comes in, evidence of congestion, shortness of breath. What do you do in the first consult? Definitely I would start some frusemide, because step one in all these patients is, achieve euvolemia. And beta blockers especially, we know if you start beta blockers when patients are overloaded, they do badly. And that's when you have trouble with hypotension and worsening heart failure. So one of the tenets of starting beta blockers is to maintain or achieve euvolemia first, but I think for all medications, step one is get the volume state right, and you'll improve their symptoms as well. And then my first go-to agent in that case would be an ACE inhibitor, because you're probably going to be able to sneak some of that on board pretty quickly without problems. A week or two later, yeah. I mean, it's not all day one. It's up to you. Maybe if their blood pressure was on the elevated side, I'd say start on today. If it was borderline, maybe I'd say, look, let's just get the volume state right first, come back in 2 weeks and we'll start the ACE inhibitor. Yeah. And then I'd leave the beta blockers, for maybe a month or two until we got a decent dose of the ACE. So I usually don't go all the way to 10 in the ACE inhibitor before introducing some beta blocker. I always try and get up to 5 in an ACE inhibitor and then get some beta blocker on board. There were trials with trying to do one before the other, and nothing really worked better than the other. So it doesn't really matter the order that which you do it.
Thank you for your wonderful presentation. Just, AF in heart failure, beta blocker, does beta blocker have prognostic benefit in AF with heart failure?
Yeah, this is a hotly debated topic, even amongst my colleagues. So there are some trials they've been small that have looked at beta blockade in heart failure with reduced ejection fraction and atrial fibrillation and have shown no benefit. So some people took that as saying, well, if you've got atrial fibrillation, the beta blocker trials don't apply. But if you go back and look at the beta blocker trials, significant proportions of those patients were in atrial fibrillations in some of those trials, and sub-analyses of those trials show the same results in AF patients as non-AF patients. So my practice is I think they do work, but I think the jury is out. And it probably comes down to what do you need the beta blocker for? So if they're in rapid atrial fibrillation, well, it's a no-brainer, easy. The problem is when you get, like the guy who we did on Friday with the CRT, his rate was about 40, left bundle, atrial fibrillation, heart rate of 40 on 10 of bisoprolol. And is the 10 of bisoprolol making him better or not? Yeah, it's hard to know, but I think the antiarrhythmic benefits, there's no reason why the antiarrhythmic benefits wouldn't work in atrial fibrillation and only work in sinus rhythm. So, the problem is that the evidence is split. Yeah, but my practice is still to use them. Yeah.
Is there any head-to-head studies on ACEs versus ARBs?
Yeah, there's a few comparative studies. So they've done, valsartan versus ramipril, something like that, and they seem to be equivalent in those studies, but they're much smaller than the larger studies on the ACE inhibitors that came out first. And it's also the order with which all these things got found. So ACE inhibitors got found to work first, so they've always been kind of first line. But with Entresto coming on board, although now it's not, you can't just start someone on Entresto, you have to start them on an ACE or an ARB first and swap, but that will be temporary. In 5 years' time, we just won't be using any of the others, we'll just be using Entresto or another agent. No doubt there'll be more, other companies will jump on board this idea, and there'll be more ARNIs around. It's the class of medication. So I think in general, we think they're fairly equivalent, but there's just stronger evidence for the ACEs. Yeah. Yep.
Sorry, just a moment. There you are. Could you just comment on the role of exercise in heart failure and what you recommend to your patients, please? Thank you.
Yeah, I didn't do anything about the non-pharmacological management. So But I think really that side of things is key. And more and more times that we study this, we just there's just never a negative trial. So atrial fibrillation, you can do everything you want for atrial fibrillation. If you can't get the patient to lose weight, it doesn't matter. It won't work. Weight loss for atrial fibrillation works more than any medication that you can come up with. It's better than amiodarone. It's better than an ablation. So we know that, in that subset definitely, but in heart failure patients in general, and including in heart failure with preserved ejection fraction, exercise is key. And I just say to my patients, once you've excluded ischemia, exercising is not going to hurt them. If you don't know whether they've got triple vessel disease or left main, then you probably need to work that out before you go saying exercise. But once you've excluded ischemia, then I say the more you can do, the better. And then it's just up to whatever works for the patient. These days, all the pool-based therapies are working very well, but some people just prefer to walk around town, whatever it is. But I just go by the guidelines for normal people as well, at least 4 to 5 times a week for half an hour at a time, moderate intensity. That's what we would be asking our patients to do, yeah. And in fact, really the only trial that's ever been positive in heart failure with preserved ejection fraction in terms of what makes these people be able to exercise further and reduces their dyspnea was a trial of exercise, which kind of makes sense, doesn't it? No, it's everybody. Yep.
Any difference between BNP and a pro-BNP?
Just the reference range. Yeah, there's basically no difference in the assay and what it means, but the reference ranges are fundamentally different. But it should be on the printout from the lab. But I didn't go into BNP. I do think it's a really useful test, especially in that kind of heart failure with preserved ejection fraction. You're really trying to work out whether that, because really when you think about heart failure with preserved ejection fraction, is someone with shorter breath and has a normal echo. It could be a million things. So an elevated BNP or NT-proBNP does give you concrete evidence of congestion if you're unsure. Patients still pay out of pocket in most labs around Geelong. It's around $40 to $60. But for a one-off test, it can be very useful. Yeah. Okay. Great, thanks very much.